Welcome to the fifth episode of the In Conversation Roundtable series on the importance of place and its influence on rural and remote health and wellbeing. My name is Kamal Williams and I'm the Director for the Centre for Health and Policy's Research Translation and the Founding Director of the World Health Organization's Collaborating Centre on Health and Policy's Implementation. To start today, I'd like to provide an acknowledgement of country. In the spirit of reconciliation, the Centre for Health and Policy's Research Translation and the National Rural Health Alliance acknowledge the traditional custodians of country all throughout the world, and we want to acknowledge their connections to land, sea and community. We also pay our respects to their elders, past, present, and we extend that respects to all Aboriginal people, Torres Strait Islanders and Indigenous people around the globe today. So you may be asking, well, what is the In Conversation series and why have we brought this to you today? So the Centre for Health and Policies has worked with Professor Evelyn Deleu, who's a Professor of Urban Health and Policy, to develop and deliver the In Conversation Boundary Spanners, Thinkers, Policy Actors, Roundtable series to raise the profile of topical and challenging societal problems. And we also want to highlight their potential solutions with the aim of helping to progress understanding across research, policy and practice communities and assist in moving each of these issues forward through increased collaboration and thoughtful action. In today's fifth episode, so we've done 5 up to now, of the In Conversation Roundtable series, we've partnered with the National Rural Health Alliance to convene today's webinar with a focus on place and its influence on rural and remote health and wellbeing. The roundtable discussion will focus on the crucial role of place as a cultural determinant of health and wellbeing and to shed light on the benefits and challenges of living rurally and remotely. We also hope to explore ways that rural and remote communities can be really supported to optimise their health and wellbeing and realise the benefits of living in place. We're really privileged to be joined by a range of expert roundtable speakers and a rapporteur today to help lead our discussion, and I'll introduce each of them to you now. To start with, I'd really like to introduce Suzanne Teagan from the National Rural Health Alliance, our partners in convening today's session. And I'd like to introduce Susie to introduce herself. Over to you, Susie.
Thank you very much. I'm Susie Teagan. I'm the CEO of the National Rural Health Alliance, but above everything, really, I'm a passionate advocate of rural, remote and regional Australia. And I've lived in Alice Springs, Darwin. I've lived in the southeast of South Australia for 30 years on a farm. And I've lived in rural Victoria and New South Wales. And why is that important? Because that is how you know what actually happens on the ground. And the National Rural Health Alliance supports and works with its 48 members and other stakeholders. And those members are people and organisations that deliver healthcare on the ground from the patient journey, the day they're born, all the way to the day that they pass away. They also work in education and the future workforce from the day people decide they want to study either health or medicine or other health-related careers, all the way to the end of that career journey, and also research from the day a problem is seen to the end where there is a policy developed, so the funding is provided, or there is some change in the community. And we also have a journal. The Journal of Rural Health is a multidisciplinary and interdisciplinary journal which provides grassroots research and the networks and partnerships that develop in rural communities. So we're here because this is our passion and this is our remit. And we believe that rural and remote and regional communities, the 30% of the population that make up these regions, are important. Thank you.
Wonderful, Susie. That's a great introduction to the National Rural Health Alliance, and we feel very privileged to be partnering with you to convene this session today. And I now will move on to introducing the rest of our esteemed speakers. Each of them will be asked to speak on their perspective of the topic for about 6 minutes. And following the 5 brief presentations, time has been allocated for discussion and dialogue between the speakers. So it'll be helpful if you have questions, please pop them in the chat during the webinar, and we'll do our best to identify and try to answer them as we move through today's discussion. I'd like to start by introducing, I will run through all of our speakers and then I'll invite Timmy to take the first session. But let me introduce all of the speakers to you first. So Timmy Duggan is the founder of Hoops for Health. He's born and bred in Darwin, and he was the first person from the Northern Territory to play in the National Basketball League and is the only Indigenous Australian to play in the National Basketball Leagues during the 1990s. Our next speaker will be Susie, but she's already introduced herself, so I'll move forward to our third speaker, which is Associate Professor Ian Butterworth. Ian provides an interface between policymakers, researchers and citizens. He is founder of Ian Butterworth and Associates, a specialist healthy cities and livability consultancy, where he leads community engaged partnerships that put livability, community capacity building, quality of life and sustainability at the centre of policy, legislation and urban development. Professor James Smith will follow Ian, and he is the Deputy Dean of Rural and Remote Health in the Northern Territory, and he's Matthew Flinders Professor for Health and Social Equity at Flinders University. He is an applied social health researcher with 20 plus years experience working in rural and remote health policy, practice and research, context in both South Australia and the Northern Territory. And he's had a particular focus on improving Aboriginal and Torres Strait Islander health and education outcomes. James will be followed by Rodney Green. And Rodney provides support across the Burnie Works initiative, an area such as strategic and systems thinking, facilitation and stakeholder engagement, both locally and with external partners. He also supports the board of Burnie Works Limited in carrying out their role. He has worked across private, public and not-profit sectors and is committed to whole of community responses to issues they identify as important. And Burnie Works, not surprisingly, is located in northwest Tasmania. And finally, I'd like to introduce our raconteur who'll come to summarise today's session following our speakers. And this is Dr. Matthew McConnell. He's a public health physician at Rural Support Service in SA Health. Dr. McConnell has over 20 years experience within various roles as a medical professional and educator. His current role involves providing health expertise and support to the 6 regional local health networks here in South Australia. And he has a keen interest in health policy and the determinants of health. He's been actively involved with the South Australian Health and Our Policies approach for over 10 years. And we'll hear from Matt just before the end of today's session. So as we move to start today's roundtable discussion proper, I thought it would be helpful just to sort of outline the topic of today's session. The concept of place is multifaceted and includes multiple factors. For example, the sense of place describes how people relate to and perceive places in different ways, such as through emotions, memories, meanings, stories, and sensory experiences. It can evoke feelings of belonging, comfort, or anxiety towards a place. And it can include things like home, neighbourhoods, and even cities, although we won't be talking about that today. Rural areas have their own distinct cultural characteristics, including traditions, norms, values, and social practices, which can influence the health and well-being of residents within these communities. People living in rural and remote Australia have strong connections to place, and this can provide a protective buffer to the challenges faced by these communities. The role of place in creating health and wellbeing is really growing in recognition amongst researchers and policymakers, and there is such a great potential for us to learn from our Indigenous communities and rural communities on how to amplify these benefits. The choice of where we live can make tangible differences to our quality of life. People in rural and remote areas face a range of stressors that are distinct from those living in major cities. Access to services, including healthcare and social services, can be limited. The influence of social and cultural determinants of health are often poorly addressed. And the attraction, retention, and mobility of the workforce, including the health workforce, is an ongoing and significant problem. Today's speakers will shed light on the benefits and challenges of living in rural and remote Australia. I'd like now to invite Timmy, our first speaker, to share his thoughts on the topic. Over to you, please, Timmy.
Yeah, thanks for that introduction, Carmel. And yeah, when I think of place, I'll talk a bit about our Hoops for Health in a moment, but I really have to go back to my grandmother's place of birth on her Warramungu country. So on my mum's side, even though I'm born and bred on Larrakia country up here in Darwin, on my grandmother's side, on my mum's side, I'm a Warramungu man, and on my father's side, I'm a Nigana man from over in the Kimberleys. But before I even start talking about Hoops for Health and its role in place, I've got to talk about my grandmother's journey and her place, which was a place called the Phillip Creek Mission, which is about 1,000 k's south of Darwin. And what happened? She was taken from that place, forcibly removed to a place called the Retta Dixon Home here in Darwin on Larrakia country. And it wasn't until it took her 20 years before she went back to see her mum on her country. That's how long she was taken from her place. So with that taking away from her place came a lot of those words that Carmel just mentioned: anxiety, identity, all of these things because of being removed, language, belonging, who she was. But the thing that she showed us a lot of love. But what this led to was a lot of trauma, and this term called intergenerational trauma, which a lot of our, not all, but a lot of our families and communities face, especially from past policies and such. So I just wanted to give that background on the place because it kind of mirrors our journey with Hoops for Health. And I use my grandmother's journey of resilience to really push us along for our journey at Hoops for Health. She passed away at what I thought was an old age, which was 53 or 54. When I look back on it, she never drunk, never smoked. But when I look back at it, she actually passed away from these inner traumas that were happening that was ripped off her place, and all those things that would have been going on just to have a normal night's sleep at another place. So fast forward to about 1995, I had a vision along with a couple of other of our workers to design a program that used my basketball background. And then I was prompted and kind of inspired by what was happening with the Aboriginal Community Control Health Service scene to start this program to blend my Aboriginal health knowledge and my basketball knowledge. So we started Hoops for Health back in 1995. And where we visit, places that we visit, are some of the remote places on Earth, some of the most vulnerable places on Earth, including Northern Australia, Central Australia, down into South Australia, Western Australia, and even over to Queensland. Look, it's more than basketball, and we impact our communities through what we call a healing-centered sport approach, using a lot of the terms derived from Dr. Bruce Perry's neurosequential network, which is, a big term for looking at ways that you can train the brain to maintain, but also using our First Nations knowledge to develop relationships and our experience of working with our communities as well. So combine those two together, we've got a pretty powerful model. As I mentioned before, a lot of the places that we go to have third world conditions, living day to day to survive, and let alone have a nice basketball court as one of the pictures here. So a lot of times when we go to these communities, we'll look at the courts or look at the condition there, and we might even work with them around improving the basketball court, the facilities, to ensure that people have got good places to do some exercise and shoot some hoops. So what we did, I'll get you to go to the next slide there, is we got pretty innovative about it. And we saw that there were these trailers that could be turned into basketball hoops. So these places that didn't have courts or stadiums, we can actually take the court to them now, to these communities. So this one here is right in the heart of Darwin, in a community right in the heart of Darwin here, where we go once a week, and we take our portable court. Inside there's also a layout that you can lay out, but you can also just pull it up on a bit of dirt, or as here in a bit of a car park as well, and off we go. We're shooting hoops. So what it does is we're able to take our hoop to far-reaching places, you know, and the most remote places in Australia. When we do it, I'll get you to go to the next slide, Carmel. Yep. So when we do it, we use those terms from Dr. Bruce Perry's neurosequential model, but we put it in pretty simple language around this healing-centered sport. So one of the things was we want to build the resilience, not the vulnerability of our populations that we work with. So we go into the prisons, into the youth detention centres, the much profiled Don Dale Youth Detention Centre, Alice Springs Prison. So we're in these places where not a lot of other people go. So we're in there doing the programs. We want to create safe places. How do we do that? Well, we do it because it's a healthy place, but we do it through our relationships as well. So 90% of our staff at Hoops for Health are Aboriginal and or Torres Strait Islander, and you know, we're delivering what we call First Nations lifestyle excellence. We don't preach that we're to these places that we're coming in to help or rescue you. We're just having a go, and we've been going we're in our 22nd year this year. And yeah, I might get you to go. I think is there one more slide, or is that it? Yeah. So look, I will finish with some of the words we use. We've got our 3 R's. Regulate, which is to do with the bottom of the brain and ensuring, you know, the people that we work with are regulated, but we are regulated ourselves as coaches. As I mentioned before, we want to build the resilience of these places and individuals and not the vulnerability. But we also, people will use the term, I'm going to empower you, or we're going to empower your community or place. We actually put an RE in front of it, because what we're saying is a lot of these communities and individuals have the skills and knowledge and the power themselves. But it's been taken away, i.e. the example that I gave you of my grandmother being taken from her place. So now we're going to re-empower you on your journey, or whatever it is, to build these what we call doses of resilience. So yeah, that's me, and that's our Hoops for Health in a bit of a nutshell there. And that's kind of our connection to place, using our stories, our history, but celebrating our mob's success stories as well, and giving messages of hope. And because what we say is this might be the only place of hope that you have for that week. So yeah, thank you.
Wonderful. Thanks so much, Timmy. That was really, well, first of all, I think starting with that wonderful, but also, you know, difficult story about your family and your grandmother's journey in her, you know, connection with community, country and place. But I did love, it's really wonderful to hear these stories of hope and, you know, the language around First Nations lifestyle excellence. It really kind of carried for me, and the message around the importance of having stories of hope and focusing on hope and optimism, and not always be focusing on the negative deficits of communities. It was really important. So thank you very much for sharing those stories with us. Now can I please invite Susie to speak about her perspectives on the National Rural Health Alliance perspective. Over to you, Susie.
Thank you. Just if I could have the slide up. Thank you very much. So one of the things about rural, regional and remote communities, and I would suggest that it's probably people in general, if we can go to the second slide, please, is that we receive our information through our senses. And so smell, touch, all of the 5 senses help us place ourselves into our community, our world, and how we interact with people. And I've worked across education, agriculture, and health. And when I've discussed this particular component, like the what does smell and what does the feeling and the sight actually do, in rural communities in particular, this was a really important aspect. And when people retired or have had to leave where they live because of their health, it has stressed them and caused great anxiety. And if you've seen one rural town, you've seen one rural town. And so the National Rural Health Alliance works with communities and also with its 48 members and other stakeholders to ensure that when we develop policy and funding, it's very much place-based. It has to include all of the things that make up living in a rural town and delivering a service, that it is very much place-based, and we've raised the issues that exist in those regions. People need a local healthcare solution based on components of place, because otherwise you have an underspend. And that is what's currently happening in Australia. We recently funded a NOUS report, and it was evidence-based for additional investment in rural health in Australia. And the NOUS group has found that we have a $6.55 billion underspend in rural healthcare per annum. Now, $6.55 billion underspend per annum. So the question you would ask is, where's that money going to? So that is the reason why we need a population health need and local requirement-driven solution, rather than a model that fits the urban environment or fits another rural community. So it needs to be a place-based model for small rural communities in particular. It has to be locally designed and led, and place-based factors which include, do we have an older community? Do we have a large Indigenous community? Do we have a young community that might require obstetrics, gynae, and other services that you might not find in the nearby community? And the Alliance has worked on a primary care rural integrated health service, which we call PRIM-HS, with communities, and they all look very different, but they are multidisciplinary and they're very much grassroots led. And then the challenges when care is not provided locally or doesn't consider place, then you end up having people that are not seeing the clinicians that they need. The underspend sits there and is redistributed to urban centres, and services disappear from those regions. In addition to that, you have people that are getting sicker and sicker, And if you have a look at the population health status, we do not have as healthy a community in rural and remote. You have factors that impact individuals in communities, and there are specific consideration for First Nations people that have higher suicide rates, higher chronic disease issues, and less access to services. Thank you. Next slide. So the prevention in rural and remote health needs a link to place. And I think over the years, people have forgotten that. Why do we not have the workforce? Why are we not supporting more primary schools and secondary schools to encourage those local children in rural communities to consider health as a career option? Especially because we now have research that tells us that if a person goes into a health career, whether it's medicine, allied health, paramedics, nursing, pediatrics, any career, we know that if they've gone to a primary school and a secondary school in rural and remote Australia, and then they then go into training, which includes a rural component, exponentially, they're more likely to stay or to go back to those communities. Currently, we have about 56% of doctors are from overseas. Now, there is nothing wrong with having a component of overseas doctors or fly in, fly out, because you need a mix, and that includes telehealth. You need a mix of options and support mechanisms to ensure that we have the workforce. But the people that generally come on the ground from overseas have an aim of working in the city. And a very large percentage of people that are allocated to rural and remote move within a very short period of time, and then there is a revolving door for people that live in rural communities. We need to create healthy communities which include education, housing, food, physical opportunities, activity opportunities, health literacy, education, and the access. But it has to be done with communities, not onto community. Place provides social capital and provides a community approach to solving local problems. And they need to be considered by fund holders, policymakers, because at the moment, the $6.55 billion underspend per annum demonstrates that the current model is not working as well as it should. Workforce recruitment and retention options require attention to place-related factors, and they also need to support those people that are already providing the support to those communities and provide support to the students that are willing to work in those communities. Desmond Tutu once said, "There comes a time where you need to stop pulling people out of the water. We need to go upstream and find out why they're falling in." And this is about a place-based solution for rural, remote and regional communities. And the National Rural Health Alliance will continue to work with its members that deliver healthcare, that train the workforce across the health and medical workforce, and to ensure that we continue our research that is very much place-based, that we continue to receive more funding for rural place-based research, because at the moment we receive well and truly less than what 30% of the population should be receiving, and then publishing it in our journal, our Australian Journal of Rural Health, which is used by all sorts of stakeholders that serve and deliver and live and work in rural communities. Thank you.
Thanks so much, Susie. That was a really great overview of some of the challenges and some of the great benefits of living remotely, and some of the inequality really that I think is is really operating across rural and remote communities in Australia. I think I really love the way you highlighted that if you've been to one town, you've been to one country town. You can't assume that they're all the same, that each of them is unique, which is why you need that localized context and working with communities, not on communities or for communities, but engaging them in the process. I thought also it was great to hear about being a prevention person myself. Loved the Desmond Tutu's suggestion about we need to go back upstream and work out why people are falling in the river, and we could build a fence to try to stop them falling off the cliff, and that we need to be thinking about place when we're thinking about prevention as well. So thank you very much for that. So now I'd like to move on to our third speaker, Associate Professor Ian Butterworth. Over to you, Ian.
Thank you, Carmel, and thank you to my previous speakers. It's a very nice segue to talk about my interest in rural and regional livability, if you like. I've been working in this space for a very long time now. I cut my teeth. My experience of working in regional Australia was on Larrakia country more than 30 years ago, when I went up to Darwin to help set up HIV support services across the Northern Territory. That had a profound impact on me. My doctoral research on environmental education ended up looking at place and the importance of the qualities of places that really drive people's connection to place. So the previous speakers have really set the scene for what I want to add, which is this notion of livability. Where we live has a profound impact on our opportunities to access these very important drivers of health and well-being: good employment, fresh affordable food, diverse affordable housing, transport that connects us to the things we need, walkable neighbourhoods, public open space, and especially social infrastructure. So the sort of services that we expect to find in a place, in a community, to provide health, education, childcare, community support services, arts and culture, sports and recreation, playgrounds, community centres, halls, meeting places, possibly public housing, legal and emergency services, public community transport, all of these things that people in cities tend to take for granted if we're lucky enough to live in the old parts of Australian colonial cities, which are very well served by these components. Although I note that increasingly living in affordable housing makes places far less livable than they could be. When you live in a rural or remote part of Australia, these things are still important, very much so. They don't change from one population group to another. But what does happen is when you live in a rural and remote community, you need to make the best with what you have, and you often find innovative ways to deal with challenges such as transportation or employment. Could I have the next slide, please? What I really loved about Timmy Duggan's discussion of Hoops for Health is it's an example of social infrastructure that is brought to the community. So it's actually a really innovative, grounded response that's come out of community and solves a community challenge, which, as you can see here, Dr. Melanie David and her team have produced a map of the opportunities to experience social infrastructure in a community. That Melanie and her team, and Dr. Hannah Badland and Professor Billy Giles Cortai, have done these sort of maps for all of those livability dimensions that I just mentioned. But I thought I'd focus on social infrastructure because my work in rural and regional Australia, and I still do work part-time on Dja country in Bendigo, supporting communities across the northwest of Victoria with health service planning and delivery. It's often the access to places, to buildings where people actually can access a service or provide a service these are often the things that are missing from local communities, or people have to drive a lot or travel a long way to receive them or to access them. But you can see here that the policy environment is very much driven by history and culture and ideology, and it influences what we build into a place, the mix of things that are there, and also having enough people living in a place to make it viable. And then ultimately, that impacts on how people use those facilities and the sort of interactions that they build up over time. And then you have this sort of longer term, medium to longer term outcome of experience of community well-being, and ultimately their physical and mental well-being. Now, these maps tend to look at mental health outcomes because that's where the data is. But I wanted to just jump to the next slide, please. I'm doing a lot of work at the moment on this, unpacking this notion of sense of place. It's a very much a Western concept, which includes these other components of place identity, place attachment, place dependence, all anchored in, I suppose, a broader understanding of psychological sense of community. But I've deliberately juxtaposed it next to this fantastic NIDOC Week poster, because that's also a diagram of sense of place, but a far more complex and nuanced one that I think Western societies can never fully comprehend. And what I love about that is that it incorporates historical and cultural determinants along with the social and environmental ones. There's a sense of belonging and service to place, custodianship of place, that we in the West, Western people, can only begin to imagine. And Carmel and I are actually collaborating on a book called The Psychology of Place, which works alongside First Nations writers on this topic. But I think often about the Yaru elder who said, "We were born to look after this country." It's a very, very deep relationship to place that really goes beyond any of those small triangles on the left. And then you have people in politics arguing that First Nations isolated communities need to move off land to go and access social infrastructure because, quote unquote, their lifestyle can't support them. But I think it just, to me, shows the really deep understanding and connection to place that First Nations communities have. And when you actually factor in historical and cultural determinants of health, you can't not look at people belonging to place and identifying with place as one of the main drivers of keeping people well and happy and healthy. And what I love about Timmy Duggan's example is that it's a really innovative solution that brings social infrastructure to some of those places, notwithstanding that people also need fresh water and meaningful employment. But I think it's possible to work with those communities to come up with innovative solutions for building local economies that are actually about economic self-determination. And I guess the example of those livability dimensions is that the things that drive health and well-being usually fall outside the health sector. As my previous speakers said, it's housing, it's employment, it's agriculture, it's food, it's logistics, it's transport, it's parks and recreation. All of those things are outside the health sector. If we work on those things in rural communities and remote communities, my sense is that health and wellbeing benefits will flow from that, especially looking at psychological resilience factors that help to build strong, resilient communities. So thank you. I'll stop there.
Thanks so much, Ian. Another great, I know these are very brief sessions and cover these complex, deep issues, but I think each of our three speakers so far have really touched on different aspects, but you're also covering and repeating, some of the same issues. I think it's really lovely that you highlight, how critically important these innovative solutions are, such as Hoop for Health, that are actually evolving out of communities' own identifying the needs and then solving their own problems. And I think the idea that, we should be recognising and supporting communities to actually identify and work with them to help them solve their own solutions, that they can be innovative and really, you mentioned about, creating economic capital and capacity. So, and I think the fact that the idea and unpacking a sense of place is complex, and it requires some sort of, it requires us in perhaps the more Western world to really take stock and think about what we can learn from the deep knowledge that Indigenous communities bring to this concept. And I think also rural and remote communities also have a slightly different perception and perspective around connection to place than perhaps those of us that live in urban centres do. And we've got lots to learn. So now, thank you. I'd like to then hand over to James, and James is going to talk to us a little bit about research and workforce capacity. Thanks very much, James.
Thanks very much, Carmel. And if I can have the slides up as well, that'd be great. While we're getting the slides up, I do want to acknowledge that I currently work for Flinders University in the Northern Territory. We've got the footprint that goes up the Central Australian corridor. And I want to pay tribute and to recognise that I'm coming from Larrakia land today, and to pay respect to elders past, present and emerging, and that I acknowledge their connection to Garamilla, the local name for Darwin. Can I have the next slide, thanks. So I wanted to cover off on a few things today. I've been asked to talk about rural and remote health research specifically, and how place ties to that. And much of it ties into what has already been said, and that importance of both not just understanding but privileging local contexts through rural and remote research and evaluation processes, that we don't just give lip service to that, that we actually think of local context as being a central aspect to the work that we do. For me, in the work that I've been doing in the Northern Territory for the last 15 years, albeit from a Darwin base, but I've lived in very remote parts of the Northern Territory as well, including Gumbalanya in remote West Arnhem Land. It's really important to understand local protocols, local customs and knowledge when engaging in research in rural and remote contexts, and in particular Aboriginal and Torres Strait Islander communities. Recognising that the past experience that those communities have of research and or researchers absolutely impacts the perceptions of the value of research and evaluation as well. Many of those communities across the Northern Territory, where I'm based, have had negative experiences of research and evaluation, and it's really important that we do everything in our power when doing work on country to make sure that we recalibrate that. Something that I've learned over the past 15 years whilst I've been in the NT is that everything is relational. And what that means is that it's not just about the project that you're doing, but it's about those longer term relationships. And it's about having a longer term and co-design vision, that there's a lot of bicultural learning within that context as well. And I think at a practical level, recognising when you're doing research within a rural and remote health context, recognising that there's these very high costs and there's some very unique logistical considerations that you never see or seldom see within an urban-based context. So the fact that it costs, that I may only be able to fly to certain communities to do research, the fact that if I'm building capacity of community-based researchers in some of the regions across the Northern Territory, that they often don't have the same training options available to them locally, and therefore there's a large cost associated with that capacity building that looks quite different. I also wanted to talk about differences and similarities between rural and remote contexts and place as well, and I think, again, Susie summed that up beautifully earlier, in that there's no rural or remote community that's the same. They're all very different. They've all got their local contexts that need to be taken into consideration. And that for me has been a really important thing. That doesn't mean that there's not shared experiences across rural and remote contexts. Of course there is, but understanding that each place is unique is really important. I also wanted to talk within a rural and remote research context about the overlapping agendas and principles between rural and remote and Aboriginal and Torres Strait Islander health and wellbeing. So rural and remote, we often hear about the tyranny of distance. We often think about geographical locations and so forth, and often lack of access to health and social services, as we heard earlier. But within an Aboriginal and Torres Strait Islander context, we're often drawn to thinking about the cultural or social and cultural determinants of health. And as part of that, very much that connection to country. So that notion of place being central. It's not something additional to, it's not somewhere where you just live. It is part of you. It is part of your who you are, who your family is, who your community is. And I think that that's really important to understand. And of course, that whilst there can be rural and remote research that doesn't involve Aboriginal and Torres Strait Islander, within the Australian context, more often than not, it will. And that there's actually a cumulative impact there that we've got to consider from both if you like, a geographical context, but also that cultural context. Some examples there that I would give are some of the differences in thinking around Indigenous data sovereignty, which has really taken primacy in the last few years, in particular about Aboriginal and Torres Strait Islander people being involved in all aspects of the research, right from the design phase right through. And similarly, the community engagement principles as well that underpin the work that we do, and being able to co-develop those and be on the same page right from the get-go. Of course, investment in local research and evaluation capacity and capability building is critical as well. And as I said before, that can be quite challenging sometimes. We've found that working in a bicultural approach, a two-way learning opportunity there around non-Indigenous researchers can learn about cultural ways and vice versa. Our Indigenous colleagues can learn about research principles, etc., works really well. And indeed, as we've seen through some of our projects, that growth then flows from one project to another. And we then start to see a pipeline of Aboriginal and Torres Strait Islander researchers going through the higher education system as well. And I think also, and I'll talk in the next slide a little bit around some of the emerging strategies and solutions. So if we can pass on to the next slide, please. What I wanted to show here is that what I'm saying today is nothing new. There are lots of researchers nationally and indeed globally that are contributing to these discussions in terms of what research looks like, in terms of what place-based research can look like, the importance of investing in local researchers, creating sustainable and supportive health research environments, designing, implementing research training in rural and remote health. So I won't go into those today, but just to let people know, there are certainly lots of examples there. And for those that missed it, there was actually a special issue of the Medical Journal of Australia on rural and remote health workforce just recently as well. Next slide, please. So in terms of a call to action, this is an editorial that I wrote with many colleagues, I think it was the beginning of 2022, around advancing health promotion in rural and remote Australia. So not necessarily research, but certainly health promotion, for those that know me, is a deep interest. And again, Susie mentioned that in her presentation. Timmy and Ian both gave good examples of the type of work that's needed in and around place within rural and remote context. States and territories need to be really thinking about what rural and remote research looks like. On that note, I'll leave it there and I'll hand it back to Carmel. Thanks.
All right. Thanks a lot, James. I really appreciate that. Sorry to interrupt, but I am very keen that we can have some cross discussion between all of the speakers following our last speaker. So Rodney, can I please invite you to come and speak with us? And I think what we're hoping that you'll do is share with us some ideas about strategies that can be used to really support the sense of place and build the health and wellbeing, help support the health and wellbeing of people living rurally and remotely in Australia. Over to you, Rodney.
Thanks, Carmel. What I thought I would do is talk about an example of a local strategy solution, and also one that we are seeking to implement at a statewide level that really builds on this place-based approach. At the local level, we've got an initiative called First 1,000 Days, and that's a collaboration between Burnie Works, the local Burnie Child Family Learning Centre, the University of Tasmania, and the Burnie Community House, aiming to develop learning pathways for parents of children in the first 1,000 days, and using a parent-led, place-based approach to support and promote the key needs of nutrition, movement, environment, managing stress, and ensuring caring connections. It's a response to the real shortage of allied health professionals in the northwest coast of Tasmania. And it seeks to build the capacity of parents in early childhood development across 4 main areas. We're going to use a storytelling approach and a co-design process where parents will work with academics, allied health professionals and service providers to develop a set of learning materials and pathways for these various areas. The parents will learn about key components of early childhood development and then choose those areas that are most relevant to them in their communities to develop those learning materials. The materials will be easy to understand and have a degree of creativity. It's based on an existing little project called Look Who's Talking, which was a parent-led initiative of the local Child Family Learning Centre, and which used that process to develop learning materials for parents around attachment to promote brain development in babies. And that program is now being rolled out in other communities around Australia. But First 1,000 Days is a little bit of a scaling up, and we're seeking to not only develop this project in Burnie, but also in 2 other communities in the region. One which is a very rural community, and one which is slightly different demographics to Burnie. And what we'll be exploring is whether the parents in these other communities identify different priorities within these various areas of early childhood development. But as well as developing the learning materials and pathways, we'll also be producing a guide around the process of development. That means that other communities will be able to collaborate with their local partners to design their own specific learning materials that are most relevant to them and in ways that are culturally relevant. And apart from the learning materials and pathways, key messages will be used to design and deliver a community campaign so that all caregivers in the local community and the local ecosystem understand the key components of First 1,000 Days for their community. The other part to this is that we are really promoting a shared decision-making approach in governance of this project, so that local community members will be part of a steering group along with government representatives, and we'll be providing capability building support to both the community members and the government representatives, because we know that it'll be a learning experience for everyone, and that group will be monitoring the rollout of the project. That's the sort of more local strategy, and it's an example of a number that follow the same sort of principles. But at a statewide level, we're also progressing a project called No Less Threads, and that seeks to scale up place-based approaches like the one here at Burnie Works and in other communities around Tasmania, and really scale up place-based approaches in some of Tasmania's most disadvantaged communities. It has a focus on developing a model that's based on a number of frameworks, and that includes a policy framework, investment framework, a governance framework, a practice framework, a risk framework, data, evaluation frameworks, and then pulling it all together in what we call systems in place. Because we're convinced that most of the systems that impact on people's lives can be most effectively addressed at a local level by communities in partnership with external partners from the broader ecosystem. This project will bring together communities, community members, all levels of government, Commonwealth, state and local, community services, and a number of intermediaries, including universities, to develop a consistent model of place-based approaches. It's not just about building capability within communities, but it's also about building the capability of all these other partners so they are much better placed to be able to work with communities. Thanks.
Thanks so much, Rodney. Hopefully you can hear, those of you that are online on the webinar, that we're getting to see some common messages really emerge through each of the discussions. We're hearing about that each community is unique, and that local context is really critical and really matters. So understanding both the geographical nature of the place, but also the social, cultural and historical nature of place and communities that live in those places. I think we're also hearing the critical importance of shared decision making, and Rodney, you gave a really great example around the projects that Bernie Works is using and applying. And I really love that last point that you made, that it's, and I think James also picked up on this with his concept around biocultural learning, that actually it's really important for those of us that are trying to work with communities and to support them to re-empower themselves, that we understand that we need to do learning as well, that we're all going to be learning together, and we need our capability often developed as well. So the nature of building and supporting parents, but also all of those partners learning how to partner. How do you work with people in a respectful, meaningful way and be able to share power and decision making? I think these are really important points. So now we've come to the point of our discussion where I'm going to throw I think if we've got time, hopefully one or two questions to all of our audience, all of our speakers. And please feel free, whoever would like to answer the first question first, just perhaps put your hand up, but we'd be keen to hear people's perspectives. So I think we've talked a lot today about places, but we've only really touched on the challenges of access to services, which is really one of the things that I think is often dominated in the conversation around rural and remote Australia. So can you think about what are the key steps that we need as a society, that we need to take to create more equitable support systems for rural and remote communities? And that includes healthcare, but it shouldn't just be only about healthcare. Who would like to open the response to that question? Okay, Susie, thank you.
I'll put my hand up early. I think it takes a multi-pronged approach. First of all, you need a government or state and federal governments that are willing to work together. That's the first thing. So state, federal and local government. But you also need a change in policy. And what often happens with departmental people is that because of the politics of it all, they're often not able to, use innovative ideas or fund innovative ideas because there's a concern around, it not working out. And then, of course, it's failure. I started advocating for telehealth about 17 years ago. I've been on every Medicare item number committee to get telehealth going, and it took COVID to actually people said, oh my goodness, now we don't know. And all of the issues that people thought were going to occur didn't occur. So I think it's really about, having all the ducks lined up, and can you do that? And it also depends on, is the environment right to actually have all the ducks lined up and be able to move forward? And part of, Rodney's presentation was about, bringing the community together. Well, then how do you then come up with a governance model that actually allows everyone to have an equal voice? And that includes, the Indigenous groups, the community people, and really making sure that that is based on independence. Do you find a community leader to bring everyone together? Because I think you need that, because everyone's vying for this space and feeling more important. But in the end, you know what, there's enough for everybody. So I guess I have a view of a glass half full, but they're my initial thoughts.
Thanks, Susie. That's really, I really love the picking up the point about bureaucrats being risk averse and, really not interested in innovation. And also the other point that you raised here is that, 17 years ago, well, we know there's research that you started talking about telehealth, that it takes 17 years on average for research to translate into policy, practice and on the ground impact. So your experience, I think, backs up the research. Would one of the other speakers like to respond to the question around what do we need to do to create more equitable systems in rural and remote Australia? If no one responds, I might then throw on to the second question. Okay.
I'll respond briefly, Carl.
Okay, great, James.
In saying that I think that it's really important that when we're talking about equity and fairness and just rural and remote societies and communities, that we're coming from a really strong values and principles base to the work that we do, that we're really clear around what it is that we're trying to achieve and how we're going to achieve that. And often we don't. We'll often jump to solutions that aren't co-designed, that haven't taken local context into account, and where various aspects of equity and or inequalities have not even been considered. And it's really important to have those things framed as principles, I think, up front if we want to see improved outcomes.
And so are you suggesting, James, that what we really need to be thinking about when we're working to try and improve the systems in rural and remote Australia, we really need to be we shouldn't really be doing anything without co-design and without thinking about equity and fairness?
Yeah, but I also think we have to be, so yes to that, but I think we also have to be really careful with the term co-design. It means different things to different people.
Okay.
And unless you come from a real values base and you're clear about the principles that underpin the co-design process that you're trying to adopt, you can give lip service to concepts like co-design very easily. So there needs to be that notion of it being genuine, it being authentic, and that links to what the community needs within any given location.
Okay, I like those words, genuine and authentic. Before I move on to question 2, is there anyone else that wanted to comment? Oh, yeah. Okay, Ian?
Yeah, I hear a lot of discussions about trying to attract regional workforce to provide local services, which I guess is an expression of equity. One thing that surprises me sometimes when I engage with traditional health folks is that they really don't have an understanding of regional development and the need to engage in discussions with economists and departments of regional and regional planning about building up the economic self-sufficiency of local places and engaging with universities and education providers to provide that training that Susie was talking about, which can then lead to long-term viability of people living and working in rural and remote places. The issue of housing has suddenly exploded across regional Victoria as people flee the cities. So I think when we talk about equity of health, we need to look at those very strong upstream drivers that lie outside the control of the health sector, but which are so crucial to being able to provide services within place or to a local community. So I encourage health folks to think outside the box and think about all the drivers that make for a healthy, strong, livable place, and start conversations with those policy owners, those policy communities that drive those agendas.
Thanks, Ian. I mean, I really, the economic self-sufficiency and, being able to help support and understanding the role of regional development is really critical. And certainly something that those of us in the health system don't normally get exposed to through our usual course of work. We have to actually go out of our way to understand it. I might quickly throw to the second question and just have a couple of initial thoughts. And then I think we'll have to wind up because we're running fast out of time, and I do want to have time for Matt to do his raconteur reflection sessions. So the second question is really about, we know that place plays a very important role as a cultural determinant in rural and remote health. How can policies, practice and funding, as Susie keeps mentioning, very importantly, be tailored to recognise and amplify these relationships? Did anyone have any thoughts about that? Rodney.
Thanks, Carmel. Look, I really feel that that the key consideration must be, how can communities lead this work rather than continually having things done to them. The conversations we have with communities, they get really fired up when it's always people coming to the community with a solution already packaged up, ready for them. So I think as a first principle, and James has talked about a couple of others, but we really need to make communities at the centre of the solutions that to address the issues that they face.
Right, absolutely. And I think that picks up and reinforces lots of the conversations around local context and unique circumstances and working with people. Did anyone else have any thoughts?
I was just going to say, Carmel, I think the important thing is to actually start in rural communities. People are all enmeshed. So in the city, you can afford not to be really tight with everybody. I mean, even though you may not like people, you have to be enmeshed. So all of the professionals know each other somehow because they have to work together. You've got the services, the school, the hospital, they're all somehow enmeshed. And if something happens to one of them, there's a domino effect. And so it is important to have that meshing. And I think I think the important thing is to actually work across the sectors. If you're looking at health, you don't just look at health. You're looking at infrastructure, you're looking at economic development, you're looking at primary industries. I mean, if you put it in context, rural, remote and regional Australia, those 7 million people produce 90% of Australia's food. 90%. They bring in 2/3 of Australia's export income. And that 30% of the people bring in 50% of the tourism income. And the problem is there is a disconnect and people don't understand how important these communities are. And by working across all those different sectors and by bringing all those sectors in, you can actually start having a solution that is a regional-based solution. Because if you're just working in your health, for example, or research stream, you're always just going to be there, but you're not actually going to influence others. And, my greatest learnings have been from working in different sectors, education, agriculture, economic development, because you can apply them across the sectors. But I think that is a very big component, an important component of any sort of planning.
No, that's really helpful, Susie. And I mean, of course, you're speaking to someone who's completely immersed in thinking about working across sectors with the health and our policies approach, which is exactly what that's about. It's about how we can build, how we can strengthen, policy integration across government and levels of government to get better public policy outcomes.
But within that, Carmel, I think something that Susie's pointing to is that there's a huge opportunity to really champion a health in all policies approach within a rural and remote space. You've got people that are more closely connected often to be able to work across those different disciplines, domains, sectors in ways that it's much harder to do often at a state or a national level. So in that way, it could be a bit of a flip, if you like, in that we can actually learn from the way rural and remote communities approach some of these issues, the way Aboriginal and Torres Strait Islander communities approach some of these issues, to inform how to do that work at state, territory, national, and even global levels much better.
Yeah, no, that's really helpful. Thanks a lot, James. And yes, I do think there's lots for us to learn from obviously the way rural communities and remote communities and Aboriginal and Torres Strait Islander communities are able to partner, work together, collaborate, and, you know, work across systems, break through those silos. But we're running fast out of time, so I will wind up the questions now, and I think I'll throw to Matt. Clearly, Matt, it's tight, so but hopefully you've a far-ranging conversation. So over to you, and we look forward to hearing your summary of our discussion and perhaps some ways forward.
Yeah, look, thank you very much, and for a great In Conversation Roundtable series this afternoon. Really exploring and expanding on the importance of place and its influence on health and wellbeing. Just like to acknowledge and thank all the speakers for the breadth of expertise and experience in what's been a very enriching conversation this afternoon. I'll try my best, Carmel. We've had quite a complex and deep discussion, but some of the themes I think I'll draw out starts with the context and construct of place. We've heard from our speakers today, you know, the complex nature, the multifaceted, dynamic nature of place. And I guess we can all identify what we might think of as health promoting places and even health challenging places, you know, places that may be challenging a sense of health and well-being. We had messages of place, social capital, community resilience, and really looking at an ecosystem, really, you know, capturing determinants of health, environmental, socioeconomic, cultural determinants of health, also in capturing the domains of livability. And I think the themes that people have all drawn on around that, you know, housing, transport, open space, employment. Another key theme in sort of unpacking that was around acknowledging the diversity of places and necessarily, you know, underscoring the unique characteristics of places, noting that people can have shared experience, but really, I guess, taking the time and understanding to unpack that construct and the local context. I think that was a really key theme that came out this afternoon around the local context of place. Extending on from there, then, I think is that notion of relationships with place. You know, the sense of place, identity, attachment, and dependence. Also, I think extended very nicely out into the notion of being a place custodian, and acknowledging that sense of belonging. Again, understanding that interrelationship between people and place, and also people within community, the notion of partnerships. And I think together underpinning then the notion of place-based approaches. I think then in terms of themes around rural and remote places, looking at ways to support health and well-being, needing to understand the role of place to support health and well-being. And I think Timmy's example, for example, with the healing-centred sport approach, using hoops for health to build resilience, impacting places and having that flow and effect to people's relationships with places, was a good example of that. Then we're exploring, you know, how do you support place-based approaches, and again, partnerships coming up, and a very clear, resounding theme about investment. And I think Susie made a great case and put forward that notion of the inequity of funding and resources, and the notion that really we need to be advocating for investment, need to have locally designed and led approaches, responding to local population health needs, and adopting place-based models. And examples of that today from the NRHO, the National Rural Health Alliance, the primary care, rural integrated health services, and also the Bernie Works approaches, looking at community-led responses to issues around education, employment, and the first 1,000 days. We then talked about some of the workforce challenges. I think that's quite interesting, looking at initiatives needing to consider those links and relationships to place, creating healthy communities, building health protective factors, looking at other enablers such as health literacy, for example, and then explore strategies to strengthen people's relationship to place and their contribution to health and well-being. But I think in that interrelationship, looking at then the role of place to support their health and well-being as well. I think it was much more of a dynamic interplay that was outlined this afternoon. Noting, I think, as a theme, that recruitment and retention then strategies require an attention to place-related factors. And I think, for example, some of those recruitment and retention processes may consider some of the person-based factors, but they may not always consider the place-based factors. And again, I thought that was an interesting nuance that was teased out of today. Then there was different threads, I guess, of looking at community preference for accessing services as close to their chosen place where possible, and also acknowledging, as was eloquently put out from Timmy at the beginning, about when people are removed from place and then the negative impacts that can have on health and well-being, also extending intergenerationally. And so I think that's a really powerful understanding of that need. And I think then why the importance of place, whilst it can have different significance, there might be different factors that are significant for people, but at a sense, I think that was well captured this afternoon. I think then we sort of segued into around building research capacity and capability. And some of the take-home themes I got from that was around, looking at partnerships was a very key theme again this afternoon. Looking at innovative models, investing in place-based solutions, having rigorous and appropriate evaluation and research activities, advocacy, really understand the relational nature of local context. And I think James and others outlined that around the protocols, custom and knowledge. The importance of data sovereignty, community engagement principles with Aboriginal and Torres Strait Islander communities as one examples. And I think it was also worth highlighting that there are useful published examples to learn from. And I think that might be another component here where there might be a synthesis or a snapshot of what's already there, noting that often the time delay between research and translation, I think perhaps then it might be useful to do that synthesis, create the snapshot, and then use that shared learnings to inform future innovative practice. Finally, looking at some of the questions, designed to sort of tease out some of the where to next thoughts. But again, I thought in the presentation today, it was very interesting, especially when thinking about access to healthcare and some of the narrative we hear about providing that access to healthcare. And if we flip it back to having those supporting systems, those place-based systems to build and support community, and move from there, underscoring partnership, policy change, supporting innovative models, definitely the investment, being careful with our engagement models, and also underpinned by an authentic values-based framework. I think they would be how I'd summarise across the speakers today some of the themes that were presented in such a great way. So thank you very much.
Thanks a lot, Matt. That was really a great summary of what's been quite a far-reaching and, you know, deep conversation around the role and concept of place in in rural and remote health and well-being, and broader in rural and remote communities more generally. In the interest of time, I won't try to kind of summarise anymore. I think that you've done a great job, Matt. And so at this point, I'd really like to take time just to acknowledge and thank each of our speakers. I really appreciate all of the time that you've provided and all the insights that you've shared and the contribution to today's conversation. So, and I guess I do want to sort of remind people that it's been recorded, this webinar, and the link will be made available. It will be shared with each of those of you that registered, and then we'll be working to summarise into a pithy policy brief some of the key messages that has emerged from today's discussion to really help progress the conversation around how we can really support the embedding of place-based approaches and the using an authentic values-based framework and principles that I think that's really been emerged today. So thank you so much, Timmy and Susan and Ian and Rodney and James and Matt for summarising. And thank you all, for those of you online, for listening today. It's been a real great privilege to be here. And we look forward perhaps to you joining us with our next In Conversation Roundtable, which we plan to have on the politics of water. And I'm sure there'll be a rural and remote overlay on that one as well. Thanks very much. Good afternoon.